we're starting to understand if we eat better and smarter and we take care of ourselves, we actually won't need a lot of those pharmaceuticals and medications, right? There's some very basic things that we can do for ourselves, both early in life and throughout the lifespan, that will in fact keep us from getting chronic diseases. Much of it is decision-making and diet and some of the choices we make about ourselves. So we believe that with precision nutrition, we can not just help preemies, but certainly help even term infants.
Welcome to the Digital Health Cast, a podcast where we showcase healthcare pioneers innovating modern day medicine. I'm your host, Dr. Mwata Dyson. Now, what if I told you that the nourishment your body receives from the time that you're born till about maybe your third birthday could significantly impact whether or not you develop diabetes, obesity, or other chronic diseases, some which may be irreversible? Well, that just happens to be the case for one group of people. I'm talking about babies born prematurely. And the long-term effects outweigh just individuals and impact families. They also impact states and nations. So much so, some studies suggest that nations that don't invest in the well-being of maternal and infant health lose billions of dollars due to loss in workforce productivity and escalating healthcare costs. For this reason, economists around the world have sounded the alarm, and they're wanting and asking us to invest heavily in nutrition and in developing well-being programs specifically geared towards maternal and child health. My guest today is not only up to the challenge, she's also leading the charge. Joining me today, I'm pleased to have Tracy Warren. She's the co-founder and the CEO of Astarte Medical, the only precision medicine company using software and predictive analytics to improve infant outcomes. Let's go ahead and let's jump right in. Tracy, thank you for joining us today. It's a pleasure to have you on the show.
Thank you for having me.
Now, before we get started, I would love to just learn a little bit about you. Specifically, what got you involved in working with nutrition and improving preterm infant outcomes and leading down this path to starting Astarte Medical?
So my background's actually in finance and, believe it or not, venture capital. So I'm a recovering VC and spent the last probably 8 years of my venture career investing in women and infant health companies. So I do believe this space is poorly served. It's a huge market opportunity, but one that's typically not seen by investors as being important and imperative. So my co-founder, Tammy Jansen, and I had invested in several companies. And through that experience, met a woman named Dr. Kate Gregory, who's up at Brigham and Women's Hospital in Harvard, who's both a NICU, a neonatal intensive care unit nurse, but also a microbiome researcher at Harvard. So a very unique and brilliant individual. And she really opened our eyes to this problem about early life nutrition. And she was really the catalyst that brought us together around the Astarte Medical vision and mission.
Well, it sounds like you've assembled a very great, knowledgeable team here, and you're taking on a very needy cause. So we're fortunate enough to have, you and your team in play here. Before we kind of dive into some of the solutions that your team provides, kind of help me to better understand and, the audience, why is this 1,000 days so important? What are some of the biggest challenges that premature infants are suffering from at the moment?
Yeah, so I think for all of us, actually, from conception to age 2, that time when you're at your greatest time of growth, brain development, and overall kind of getting your start in life, it's essential that you start on the right path. And it's a pretty simple concept of, the best nutrients, the best alignment of what your body needs really can be driven by nutrition and can avoid chronic conditions, many of which you mentioned in your opening. So I think what we are really focused on is, unfortunately, the United States still has a very high preterm birth rate, despite being incredibly innovative. And we do have an opportunity, I think, to help premature babies. There's about 380,000 born in the US each year, about 10% of all births. Really help get that early life start. So a couple things to know that many people don't is we're surviving babies as early as 22 weeks gestation. So these babies weigh hundreds of grams. So if you can imagine, they're not much bigger than your hand. And medical teams have been incredibly innovative in surviving these babies. So we now have a class of patients that 30 and 50 years ago did not exist. And that creates unique challenges in survivorship. And that's really where we're trying to focus, is to help those tiniest, most complex babies get their best start in life.
You mentioned the feeding schedules and how we're able to improve the survivability at such a young and early age. How does Astarte Medical, and specifically one of your solutions, Nutrition, if I'm pronouncing that correctly.
You did great.
All right, perfect. How does that help to tie up the loose ends so that we're better able to handle this complex situation of feeding such, young and such a low birth weight infants?
Yeah, so almost all what we call level 3 and level 4 NICUs. So these are our neonatal intensive care units at hospitals that handle the tiniest babies. Almost all of them have what's called a feeding protocol. They've sat around the table, the clinical teams, and decided how to feed the babies, how fast to advance, when to fortify their calories, and they call it a feeding protocol. And what Nutrition does is it takes that hospital's feeding protocol, we digitize it, we integrate with the electronic medical record, and we drive standardization of care. And what studies have shown is that by driving standardization, you can improve the achievement of milestones, and you can get babies home faster to their families. So our play is really one of both improving workflow, improving the quality of care. But the other way to look at it is, if you can standardize care around a protocol, even low resourced centers that may not have a huge academic component to their, say, clinical staff, can drive high quality care. And so access to care also is impacted.
Absolutely. So as it stands today, at least the medical centers that are not using predictive analytics software, such as yours, how are they managing this complex situation? Is there no standardized care module? Is it pretty much independent? What are they doing now? What are you hearing?
Yeah, and I think it's very typical in many areas of medicine. Hospitals spend a lot of time on these clinical practice guidelines, and they have no idea if the doctors and nurses and clinical staff are actually following them. There's really no way to audit and monitor that. So there are standards. They are communicated to the clinical teams. What I think you'll find in the NICU, which isn't unique to the NICU, is that the attending of the day has her or his approach to feeding. And if they align with the protocol, great. If they have different experiences or perspectives, that certainly comes through in the ordering of nutrition and the delivery of nutrition. So I do think, it's an area that's very similar to other pieces of healthcare.
Oh, okay. So what I hear you saying is that it pretty much is driven by whoever is in charge that particular day or who is assigned to that patient. Is that fair to say?
That's right. Whoever's on rounds that morning is writing the orders, and that certainly varies day to day in especially these larger centers.
What are the benefits then of using a predictive analytic model in comparison to just kind of these standoff models that a lot of hospitals are using?
So a couple things. One is a lot of what our software does is automate calculations. So nutrition is incredibly complex for our babies. And just to give you a sense of that, imagine you have a 500-gram baby. They're fed at a rate. So it's milliliters per kilogram per day. So whatever rate, and say that's an 80 mils per kilo per day, you've got to multiply that by 0.5, divide it by how many times a day they're fed. And that math continues to evolve day after day. So the platform really saves a lot of time in getting nutrition correctly, but also just saving time so folks can think more about what those numbers mean and look at the impact they've had on, say, the growth or other comorbidities and tolerances of that baby. So the analytics really help to create a communication tool, They standardize, what should happen, and we capture reasons for deviations. These are really complex patients. There will be reasons not to feed or to feed more slowly, whether that be a surgery or a transfusion, or perhaps the baby is having some kind of intolerance. So we want to allow, this is all clinical decision support. We are not taking the place of the doctor's judgment, but we do want to make that piece of nutrition and that decision making as easy as possible and as informed as possible.
Yeah, that's imperative in today's practices. I've heard you mentioned informed decisions, and I've sat in these meetings with colleagues when I was practicing medicine, and the idea of introducing new technology would come up. And a lot of times the audience would be split, right, of whether or not the software was actually helping us to make informed decisions or making recommendations. What has been some of the biggest challenges that you've noticed from the clinical staff when introducing this model?
So it's interesting. We were very deliberate in the beginning, and I think having a nurse as part of our founding team, who's really the bedside caregiver to a lot of this, was really helpful in our functions and our design. But our platform is entirely transparent. We show every calculation. We have the protocol and the decision tree available at all times. So we're very clear with our clinical teams. We are not superseding your judgment. There's no black box. It's very imperative, I think, to empower clinical teams and not try to take over. And that's really reduced the resistance that I think a lot of groups have seen. For us, probably the biggest challenges we see are that some folks are threatened by it. So for example, registered dietitians, some embrace it and some worry that it will put them out of a job, which is not our intention. We think they're an incredible part of the team. So I think part of it's education and communication, but we're very careful that we understand the complexities that these children represent. And the fact that, honestly, nutrition isn't taught a lot in medical school. You can probably attest to that.
Yes.
But for our babies, beyond their first couple weeks of getting them stable, all they are is feeder and growers. And nutrition becomes the only clinical care that's really delivered to them. So it is important in our patient population. And so supporting that knowledge gap is really our goal.
You mentioned the registered dietitian and then I believe the neonatologist. So who are the primary users of the system?
So we designed all the way from the NICU director down to the bedside and the nurse. So we have a bedside interface that is really the nurse or the dietitian. So the nurse is delivering the feed that has been prescribed. The dietitians are looking at the child's progress and how they've tolerated the feeds to make planning and recommendations. The neos obviously look at it. We have a rounding report that helps them prepare for rounds and gathers all the data that they usually have to do chart review and things like that. And then we have unit-wide analytics. And that's really where administrators, people doing research, people in quality initiatives can look across the unit. How are we doing? How are babies growing? Where do we have issues on, say, protocol adherence? The solution actually stands alone on that analytic basis without the protocol, but we feel that driving standardization is really where you can change the face of care.
So is the software itself a standalone unit, or is it integrated into other software in the hospital?
So we're integrated with the electronic medical record. Workflow was a huge consideration for us in designing this. We're actually listed in Epic's App Orchard. We're one of the few clinical decision support tools in that marketplace, and it's been a huge help to us in conversations with IT groups and validating that we've taken probably the most conservative approach to coming to the market and working with some of the big players. We're about through that process as well with Cerner. So I think we have to acknowledge the power and the influence of these EMRs and work in the workflow of our providers. They're overwhelmed as it is. So we did not want to do a standalone application that had to be launched anywhere. We're embedded right in the patient record.
I'm not sure if this would be easy to do, but I'm kind of a visual learner and many of our listeners may be as well. Is it possible to kind of walk through an example of, say, we have a 30-weeker kind of came into the NICU, the nurse receives the child, and how they start to use NICU nutrition to start the feeds, and how we kind of progress down this feeding pathway to getting them eating on their own?
Absolutely. So, baby comes in having been born prematurely, and they're actually introduced from what's called parenteral nutrition or intravenous nutrition. So, the children are usually fed initially through their veins. The challenge there, and what literature has shown, is that the gut needs to be worked. Your digestive system is an organ that needs to be exercised. And so, most systems, not all, do what's called early enteral feed or gut priming. And so that's really where when you start to put either an oral or a nasal tube down to the baby's gut, so our babies can't suck, swallow, and breathe at the same time. So they can't take a bottle, they can't nurse. And so they're fed via a tube, and it's called enteral nutrition. And that then is really where the practice and the platform kick in. So very small amounts, typically of mother's milk, will be delivered to the baby through their gut. Sometimes that's donor milk, but there's usually, sort of an enteral delivery of nutrition is started. And that's usually progressed over, hopefully, weeks to what's called a full feed rate, meaning they're not using their veins at all. They're getting all of their nutrition through those tubes. And that's really where the gut is functioning at full capacity. As I mentioned, it's really done on a rate, so a mils per kilo per day. So as the baby grows, there's more volume going in. And the babies are usually fed every 2 or 3 hours. So it's a very labor-intensive process to get a little bit of mother's milk out of the freezer, provide it to the baby, track whether or not they have, emesis or blood in the stool or any kind of reaction to that. And if everything is good, every 12 hours or so, you advance that rate with the goal of getting these babies to use their gut as much as possible. So the platform is used every time a feed is delivered. So it's usually between, 8 to 12 times a day. And then, as I mentioned, it's used for rounding, and that's independent of any of the analytics. So it's a high touch application.
How do we get it integrated into the EHR? How do we get the nursing staff, the dietitians, and the clinical staff trained up to, feel comfortable and, ready to go?
Yeah, very good question. And honestly, probably the most difficult part of our sales cycle and getting the platform out. Clinical buy-in is usually not difficult. Honestly, even the contracts, but IT is the toughest part. And that's because these resources are so burdened, especially in the time of a pandemic as we're in today. But even previously, I think hospital IT groups are undersized for a technological innovation. And so it's always an area of giving them comfort. So the big thing we do when we go into a hospital is we use their existing EMR to do a retrospective data pull. So we look back 3 or 5 years. We run that data through our application to benchmark how they're performing. So we set sort of a scorecard for ourselves that here's been your growth rates, your comorbidities, your protocol adherence rates, your necrotizing enteral colitis rates. All of these things we standardize and benchmark ourselves against. And then we work with the IT teams to do active integration, usually through FHIR APIs or standard APIs to connect our platform. And then we run that prospectively on an integrated basis and deploy it. We do training on the floor. We used to be on the floor. Now we do everything virtually and through video. But it's a very intuitive platform. And because they're not charting into it, typically they're just reading from it. It's very much a user interface and design that we rely on. So we have standard support and all of that. But the longest part of that is that technical implementation. The training is relatively straightforward to someone who understands the field and what we're trying to do. So that's really where we focus our time and why we chose to be part of Epic's App Orchard and things to give the IT teams comfort that we know what we're doing.
I'm wondering at the back end of that, is it some type of scorecard where you can see specifically to each maybe patient or each clinician where differences could have been made?
We do that. We do that certainly on a patient level basis. We can do it on a clinical team member basis. That's always a bit of a controversial situation. We're very careful to suggest to our hospital partners that they use it for education and training, especially if you're in a hospital that's an academic medical system and you may have fellows or people early in their career, residents, et cetera, that it may be used as training and teaching. We can obviously select to not have that provided to the group. But I think also if you think about a protocol as a decision tree, right? You come to a point, the baby's been stable for 12 hours. It's time to advance your feeding rate, say by another 20 mils per kilo. Sometimes that gets done, sometimes it doesn't. So if you think of it graphically, visually as a decision tree, we actually create a decision tree that becomes a heat map. So on a unit-wide basis, we can tell you where within your protocol most of your variations are coming. So they'd be red on our heat map as an example. And it also helps you think about training. So you're not training on the whole protocol. Most of it may be being followed, but perhaps at certain areas or with certain patients, it's not being followed. And then you can do a very targeted education, messaging, training. And so we think that's much more valuable than just you're following it or you're not on a very binary basis. We actually go down to each individual decision and then aggregate that up from a patient level to the unit level.
I'm wondering if there are any tips you could share maybe with health entrepreneurs that may be listening to this episode that kind of help them to maneuver how they approach organizations when asking them to make some type of organizational change, just from a behavioral standpoint. Is it anything you've learned along the way as you've spoken to different hospital staffs that, maybe could be beneficial?
Absolutely. I think the biggest advice I would give folks is to actually listen. So many people start in health tech because they've had a personal experience and they let that drive their passion, which is wonderful. But when you get to a customer, you have to listen to their needs, and they vary. The idea that you can sell to one hospital doesn't mean you can sell to all hospitals. In fact, quite the opposite. So listening is a huge part. Listening to their needs, listening to their concerns, understanding things that aren't part of product design. Did a new implementation just happen? Are they fatigued? Do they have a particular quality improvement effort that you can fit into? Listen is my best advice. Listen to your customers. They may not share your perspective, but you're never going to get them to feel the way you do. You need to create the messaging and the support for their needs. And so customer-centric is key for us. We really listen. We have a very experienced advisory board that we meet with often to understand, are we getting this right? And be critical of yourself. You won't get it right the first time. That's why your first few customers should be very good co-development partners. You're still not going to get it right the first couple times, but I think listening and being, very responsive to both your performance and then what your customers are telling you is imperative for success.
I'm sure a lot of health administrators and a lot of clinicians and departments can definitely find value with using a tool such as Nutrition. And that's only one of the solutions that we talked about, but I believe you offer other services as well that may be built within the same platform. Is that correct?
That's correct. And this is probably one of our better secrets yet because we're still in development. But, we talked early on about the first 1,000 days of life. And one thing that I think a lot of people read about, I'm not sure they all understand, is your microbiome and your gut health, right? It started with people talking about yogurt and good bugs and bad bugs. And I think what we're really starting to understand is your gut and your sort of intestinal microbiome is essential to overall health. It's your largest organ of immunity. It has impact on brain health, both early in life and throughout. And so we have a program we call NICU Biome, so little play there on microbiome. And we are using the world's largest data set of preterm infant microbiome. So these are from poopy diapers. We've created predictive algorithms to understand when children are going to suffer growth failure. We can do that as early as at birth and at 2 weeks. We also have an ability to then create tailored solutions. So how would I, a clinician, feed two babies who may look the same in age and weight, treat them very differently based on their gut health and the state of their gut. And that's really a big area for us. We are not a probiotics company, or we're not going to develop the interventions, but we believe that there are very significant differences between our babies. They're very heterogeneic, and we need to give better tools to help clinicians beyond age and weight.
It sounds like it would be a great add-on to NICU Nutrition. So is the idea for them to kind of work synergistically?
Absolutely. And I think NICU Nutrition gathers all the data. Microbiome is much more of a machine learning AI piece. So I talked earlier that will have regulatory implications. We'll have a lot of education for clinicians on how to use it. It will be the first of its kind to help non-invasively predict the state of the gut. And so we're really excited about it, but I do think it's something we can't take for granted, the amount of education and comfort we want our clinicians to have with that new information.
I love the idea of talking about precision nutrition and using it almost as a pharmaceutical. It sounds like you're placing a very high priority on nutrition, almost to the same level as we typically do when it comes to diagnostic tools and pharmaceuticals. So I'm curious to see what your future plans are for Astarte Medical. Any chances of continuing these new healthy habits outside of the hospital, or, where do you see this going?
Yeah, it's great. And I think one thing to acknowledge is, and NIH just put out their precision nutrition plan for 2020 to 2030. We're starting to understand if we eat better and smarter and we take care of ourselves, we actually won't need a lot of those pharmaceuticals and medications, right? There's some very basic things that we can do for ourselves, both early in life and throughout the lifespan, that will in fact keep us from getting chronic diseases. Much of it is decision-making and diet and some of the choices we make about ourselves. So we believe that with precision nutrition, we can not just help preemies, but certainly help even term infants. So those first 2 years where you're, weaning off of breastfeeding, you're being introduced to new foods, you're thinking about how to establish that early microbiome. You have very low diversity in your gut until you're about 3 years old. So these are the times where if you make good decisions and you set that resiliency, it will pay dividends in the future. So we're focused, again, all the way from prenatal to sort of early infant. We're also starting to look at nutritionally vulnerable children. So these are children who either because of diseases or conditions, nutrition becomes essential to their health and their quality of life. Many of them are treated also in children's hospitals where we have NICUs, and looking at create sort of a platform around nutrition, because again, it's very important for some of these children to get adequate nutrition to recover from surgery, from cancer, from other conditions that really put them at risk. And we do think nutrition is medicine. We just have to have better tools, because again, I don't think anyone is adept at understanding not just what you put in, but what can your gut tolerate? Because you and I are very different. And certainly you can imagine as you're very young or very old, that's even more exacerbated.
Well, you're absolutely starting them on the right path. I'm glad to have had the chance to sit down and speak with you today and to learn more about you and to learn more about Astarte Medical. And it makes me excited because it feels like the future is bright by introducing precision nutrition and predictive analytics to help our infants and our children and our future, have a great start. Tracy, I want to thank you so much for being a guest on the show today. It was an honor to sit here and talk to you. I wish you and your team all the best of success. If people would want to follow up with you and learn more about some of the solutions that we talked about today, where can they find you online?
Absolutely. So we're at astartemedical.com, nicnutrition.com, and we're on social media at both of those handles. So we welcome the chance to connect. And I want to thank you and the team at Digital Healthcast for raising awareness about this. Not everybody has a preemie and not everybody thinks about nutrition, and shows like this really help people think about what's coming and what can be possible. So thank you for having us.
It's my pleasure. Thank you for those words of wisdom and advice. Again, you can catch information that was shared here today on our website at digitalhealthcast.com. There'll be show notes as well as link to Astarte Medical if you didn't catch that information earlier. While you're there on our website, be sure to subscribe so that you don't miss any of the upcoming episodes. Until then, Tracy, again, thank you for joining us. Everyone, have a great day.